everybody, welcome. Jen Kovac-Bordnick in Washington, D.C. Welcome. We've got a tremendous program for you this afternoon. We are going to wait a couple of minutes. We're logging a couple minutes early today. But if you are joining us online, please jump in the chat box and tell us where you are joining us from around the country. We'd love to know where our participants are logging in from. So we want to see our West Coasters. We want to see Northwest. And Adam, let's find out where our speakers are from today. Adam, where are you from?
I am near Boise, Idaho.
All right, so let's see if we have any Idaho contingency out there. Len, where are you logging in from today?
Atlanta, Georgia.
All right, let's look for our Southern folks. Join us. Hello. Oh, great. Pennsylvania. Amy, where are you joining us from?
Hi, I'm in Palo Alto, California.
All right, we're looking for our West Coasters too. We know it's still, oh, it's 10 o'clock there, guys. You should be up by now, up and about. All right, welcome. All right, Pittsburgh, Boston. Good morning, good afternoon to everybody.
Seattle.
All right, Seattle, there you go. Virginia, great. Welcome. We've got a really, really amazing group of folks who we're going to hear from today on just a very important topic around value-based patient-centered care. And I think you're really going to enjoy this conversation. Amsterdam, welcome. All right.
That's our furthest. That wins so far for the furthest.
That's right. I'm looking for Dubai. We usually have Dubai. So hoping our Dubai contingency shows up today. Connecticut, welcome. Tell us where you're logging in from around the country today. Thanks for joining us. We're going to give folks just a couple of minutes to log in. We've got a great group here today. Boston, welcome. San Francisco. Okay, Amy, you got your California neighbor here. Rhode Island, welcome. Hi, everybody. Elizabeth Warren is here with us today. That's wonderful. Welcome, Elizabeth. Tennessee, welcome. All right, City of Brotherly Love, more Philadelphia. Great, welcome. All right, Idaho. Hey.
Philippine.
Is that nearby?
Yeah, that's 2 hours, 2.5 hours away.
That's probably considered close.
Very close.
All right. All right. Well, everybody, welcome. If you're just joining us, we'd love to know where you're joining us from around the country. I'm Jen Kovac-Bordnick, CEO of EHI, Executives for Health Innovation. We have a tremendous program for you today. I've got a couple of quick introductory remarks and updates to give you before we dive in. This is, again, I think a really important topic and just a great group, a really impressive crew, really thoughtful that you're going to hear from this afternoon. So I'm really excited about this program. So we're going to be talking about delivering value-based patient-centered care, specifically around oncology. And we've got three just tremendous folks. So Dr. Len Lichtenfeld, who is the Chief Medical Officer of Jasper Health. You're going to hear from him. Len is a longtime friend of EHI, used to be with the American Cancer Society. I think many of you know him from past webinars, but really welcome, Len. We're just so glad to have you. Amy Lowe is Managing Director of Emerson Collective. And is going to be representing the patient perspective here today. Amy has just got a great background and experience to share with us today. I think you're going to be really impressed with, her thoughts and perspective around her recent experience. And we're really glad to have her. She's been working with Jasper on the patient side there. So Amy, welcome.
Hi.
And we've got Adam Pellegrini with us, CEO and co-founder of Jasper Health. I think many of you know and love Adam. Previously with CVS and Fitbit, also affiliated with EHI, a great fan of EHI. And Adam, we're glad you're with us today, going to be moderating this session, and we'll get started in just 1 second. Let me just go through a couple of quick announcements before we get there. For those of you who are not familiar with EHI, and hopefully everybody is by now, but Executives for Health Innovation, we're working on 4 key focus areas this year. And this webinar we're going to be talking about today certainly is associated with a couple of different areas. So we're going to be talking about virtual care, modernizing public health, health equity, and privacy and security. These are the 4 areas that we work on with our executives around the country, doing education, research, and advocacy. This is just a sampling of some of the organizations and executives that we're working with right now. If you do not see the name of your company or your logo up there, that means you're not engaged with us. And we want to get you engaged as quickly as possible. So please reach out through the chat box and tell us that you're interested, and I will respond to you, or Amy from our membership area will, and we'll talk to you about how you can get engaged if you're interested in working on any of those focus areas. Next slide. And a couple of just updates in terms of programs that are coming up. We have a really fabulous session coming up tomorrow. We're going to be looking at health equity and public health. We've got some fabulous speakers lined up tomorrow as well. This is at 2 p.m. You can still register for that program today. Keep going, Emma. And we've got a great program coming up. I'm really excited about this one as well. May 17th, we're going to be looking at addressing workforce challenges in a post-COVID world. And I know all of us are feeling that right now with different companies, and how are we going back? Are we in the office? Are we out of the office? Are we remote? Staffing shortages all across the country right now in healthcare and technology. And we'll be talking about that. So great program as well, May 17th. And last but not least, something many of you are interested in, ensuring provider data isn't the source of surprises. We'll be talking about the No Surprises Act and provider data. And this is going to be a very interesting program as well, May 19th. So please join us for that program as well. And before we jump in, I do want to give a big thank you to Jasper for supporting the program today. As many of you know, EHI is a very small nonprofit, and we would not be able to bring you the incredibly valuable programs like we're going to share with you today without the generous support of groups like Jasper. So we're very appreciative for their support. All right, and I'm going to turn it over to Adam to just jump into the conversation here with Len and Amy. So Adam, you ready to go?
I am ready. And thank you so much. First of all, I do want to say thank you to EHI. I have been an avid supporter. I was actually introduced to it by one of my great friends, Amy McDonough from Fitbit, now Google. And she said, you've got to look at this amazing organization. And since then, I was hooked. It's got a great membership. I already see there's some requests for more information about EHI. We'll get that out to you. So thank you so much. And also thank you to Dr. Len and Amy. These are what we wanted to do with this webinar, is do something a little bit different. We're not going to show you a whole bunch of slides about solutions and architectures and digital technology and transformation. We're not going to tell you things that you already know. We all know we need to move towards value-based care. We all know that that's where the puck is heading, but we're just not there yet. We could do all of that for 45 minutes, 50 minutes. We can answer a lot of questions about digital transformation in oncology. I'm happy to do that in the chat over here. But what we wanted to do today was completely different, is a dialogue-driven approach to how do we actually put value in value-based care, and specifically in oncology. And what I haven't heard a lot in the industry is a patient advocate perspective and an oncologist perspective having a dialogue about putting that value into value-based care. And it was something that in an earlier call, we had some interesting and mind-opening concepts and terminology came out. One, Dr. Len, and I'm sure he'll talk about it, reminded us way back when, as Dr. Len and I have been doing this for a very long time, this is all my mileage right here. The one thing he brought up was the concept of RVUs in the past was actually created with the V being value. And it turned into a monetization token process, really, that had to drive efficiency, which really gets away from, in some cases, the value. And then something Amy brought up, and she always has so much amazing insights and amazing, things that stick in my head for months. But she brought up this, as a patient, we should be co-architecting our care. So what I wanted to do was really kind of bring together this dialogue of how can we co-architect care together, drive value, and then have those structures, those infrastructures that make that, enable that to happen at scale. And again, I won't actually be talking about Jasper at all during this presentation. This is not a Jasper sales pitch. If you want that, you can ask me later. But this is more about driving dialogue around value-based care and how to create holistic care. Everyone talks about holistic care. I will say we're not driving holistic care today. What we're driving is we're driving for efficiencies. We're driving to extract as much as we can to obviously health systems have bills to pay, payers have efficiencies and costs to lower. But at the end of the day, it really is fundamentally about connecting a patient to an oncologist, and how do we have a holistic conversation about the care that can get a little bit away from the efficiency of I have jammed tons of patients into my schedule because I had to, and I have no time to talk to them. Technology hasn't necessarily made it easier. I'm just going to say it. I mean, I've been doing this since 2000. And pre-2000, I was using old clinical systems and labs and admin and ERs. Technology has not delivered on the dream of freeing up provider time so they have more time to dialogue with patients about co-architecting care plans. Today, we're going to have that dialogue. I'm going to throw out some dialogue starters, and then I also will be answering questions in the chat. We already have some amazing questions asked about psychosocial, about diet and nutrition, some of those things. So I can answer those and my team can answer them over there. So I am going to start with the first question for Dr. Len and Amy. And that is, when we talk about co-architecting a care plan and having the patient involved day one in designing that care plan, how can that fit in the current, or how could it fit in the current practicing of an oncologist, so that there is really that focus on kind of almost a co-creation or the co-dialogue around care. And maybe I start first with Amy, if that's okay, just your experience that you have told about having dialogues with providers, and then maybe ask Dr. Len for his experience as well as an oncologist.
Sure. And it's such a treat to have this conversation. So thanks for inviting me. I suppose I'll back up just one step to note that I always think it's helpful to recognize over the course of anyone who moves through a diagnosis, because at some point all of us will be a patient someday. There are no doubt different chapters to the kind of arc of a diagnosis. Chapter one, at least if you're a cancer patient, and I'll just acquaint you a little bit with mine, tends to be deeply shocking, and you move to a place that's pretty one-dimensional, which is simply tell me what I must do, and it's a bit more prescriptive because you're working on the diagnosis and you're trying to sort out the breadth and depth of the situation. For me, I was diagnosed in July of 2019 with stage 4 colon cancer. I didn't have any obvious symptoms, didn't have any family history. I actually hadn't even been feeling all that unwell. I just got, kind of on a rocket ship to a new planet. And so that really wasn't, I don't think, the time for a lot of nuanced dialogue about which path should I take and how should we think about this. What I needed was as much clear information about whatever playbook existed for patients like me to move into. And that made great sense. I'm now about 3 years into this, and the chapters have evolved to a place where my conversations with my care team are far more nuanced around everything from the kinds of therapies that make most sense for me, how to think about the year that I have, the obligations that I have, how to layer on treatment with the rest of my life that I'd like to live as fully as possible, pursuing avenues that might be some that I would bring to the table that some of my care team might not be as sort of equipped to sort of offer because it's just a little outside of their specialty area. And what I've discovered as I've moved through my diagnosis is that the chapters have moved far more to tell me what I should do to a place of how might we find this path together that fits best for the goals that I have for my life and what the best science and the data and the medicine can bring to bear. And I can get into more specifics of that, but I think it is fair to recognize that those conversations really are fluid and they move over the course of a patient's trajectory.
So Adam, you asked the question, how do you make that happen? And clearly, different people come to the situation with different perspectives at different points in time. But one of the critical pieces that I think is so important is for usually initially the physician, the clinician, giving permission. I hate to say giving permission because you shouldn't have to give permission when you're a patient, you shouldn't feel, but give permission to have those conversations. Open the door, show a willingness, listen. A lot of times these days, I mean, you mentioned earlier about efficiency, RVUs, and how we pay for a lot of docs are on a treadmill, and they have so much time and they've got so much to do and they're being clocked on it, and that is how they are compensated. That doesn't lend itself to an environment to sit down, look someone in the eye, maybe hold a hand, and say, what is important to you? And not as to share that with me today, but share with your team over the course of your care that door is open. Yes, there's some outstanding clinicians and many clinicians who do that. And unfortunately, there are many who don't. And the critical part of that is to meet that person, that patient, and their family and their caregivers, to meet them where they are, not where we are. We are highly educated. We have very focused goals. We know we need to move on to the next person, but not everyone is in that space. And I always talk frequently about we have to, we look at the world through our eyes. We need to start looking at the world through others' eyes. And one of the key issues, we're talking about value-based care, is whose definition of value is it? And we need to understand what the value is of that person who's coming in. One example, and then move on. Several years ago, I got a phone call from an older person, a woman, who had been a nurse at a major cancer center, whose sister developed a cancer, esophageal cancer. She told me at the time that I could share that story. She was in her 70s. The sister was in her 70s. No one ever asked her sister what her goals were from treatment. And quite honestly, your goals may be different based on where you are in your life. And the call to me was, can't we do something to have the clinicians talk with the patient and the family, what the patient and family goals are, because they may not be every treatment possible with every side effect to achieve an outcome that may not be very good to begin with. And that is important that people have those conversations. And I think we need to set a culture that expects that. And as we move to value-based care, which is a different model of care, hopefully those conversations will become a much more integral part. It doesn't have to be the doctor. It may be, the nurse, it may be another person on that team. The nurses are absolutely fantastic. And I always counsel people, make sure you stay close to your care team, your nurses, because they're your best advocates. But no matter who it is, that you are able to feel comfortable having that conversation.
Fantastic. One topic that comes up in of Jasper Health's members, those who have signed up to use Jasper, almost 14,000 members today have signed up to use Jasper or using Jasper. One of the, I would say, number two, if not in competition for number one interest from all of those members since the inception of Jasper, has been diet and nutrition. And I know we talk about it. I know we think it's incredibly important. But it seems to me that there's a rift between the clinical, the clinical, I don't want to say mainstream clinical thinking and the demand from patients for nutrition and diet guidance, and it's lacking. And so the question is, how do we take the psychosocial elements of nutrition and diet and build that into the value-based model, or build that into the current model, so we don't have to wait for the future dream of value-based care. And I would love to get both of your perspectives. One, Dr. Len, your perspective as a clinician for many, many years on diet and nutrition, and it's probably in many cases not being reimbursed, but incredibly important. And then Amy, your personal experience in looking at nutrition and looking at diet and lifestyle elements, that probably had to be sort of secondary wrappers around your clinical care guidance. But would love to get first, Dr. Len, your take on that, because it's not only come up with our number one or number two need from the 14,000 Jasper members, but even for this webinar, we've had at least 5 pre-questions about diet, nutrition, and holistic care as part of the clinical protocols.
Let me be a little fundamental and then talk a little bit and then enlarge on that. There's a huge workforce issue. Okay, we need people who are knowledgeable. I'm not talking about somebody who's sort of read a book about it. I mean, people who are knowledgeable about cancer-related diet and nutrition, and we do not have enough of those folks. When I was at the American Cancer Society, I will share that we spent a substantial amount of time and effort creating guidelines for patients under treatment and guidelines for the prevention of cancer. But the reality is that the number of people who could be utilized to help provide that service, we don't have those numbers. But let's talk about something else that's important. As we talk about value-based care, more and more we need to be talking about team-based care. And we need to be talking about access to the team. And we aren't giving a plug for Jasper, but one of the things Jasper can do is create that access. Most oncologists in an office don't have a dietitian readily available. And when you make an appointment, it will be weeks, months away. I have to tell you, one of the most difficult situations that I've run into recently was somebody who lives in a small town in South Georgia and is a friend of our family who has a very serious cancer, went to a major medical center to as a head and neck cancer. I would have expected a team of people to be engaged in that person's care and intimately engaged in checking up on them. Over time, as a result of major surgery and radiation therapy, his mouth literally scarred shut. He didn't have any therapy, physical therapy, to help him avoid that or work about that. And he didn't have anybody offering him nutritional counseling. He was diabetic, he was overweight. He lost so much weight not being able to eat that he ended up in the hospital in distress. That never should have happened. There should have been a team of people as part of his head and neck program, the head and neck treatment program. And maybe there were, and maybe he didn't connect in some way, shape, or form. Granted, that's a possibility. But that was a sad situation. That happens all the time. And we as a profession, we as people, and I say providers, I mean in the large scope of systems of healthcare providing care, we don't pay a lot of attention to that. We pay a lot more attention to all the fancy stuff we can do, all the surgery, all the fancy radiation, all the fancy treatments. We pay a lot more attention to that. That part's easy. When it comes to the nuts and bolts like nutrition, we don't pay anywhere near as much attention. So a big shout out for us doing something. And in a value-based system, that should be an integral part of the care we offer.
Amy, your thoughts on this? I mean, and specifically, since I know your story, you had to almost, I don't want to say cobble but you had to be creative in creating your own team.
Yeah, and I'll just say I'm fortunate, but hopefully also some of my story has some resonance across. So I'm deeply fortunate. I live in Palo Alto. I have had surgical care from Stanford, extraordinary surgical team there. My oncology care is provided through my local health system here in Palo Alto called Palo Alto Medical Foundation, a great team there. And then I have some specialists up at UCSF in San Francisco who are also advisors on my case. I did that a bit on my own, and through my own personal network, I kept adding some folks together. And one of the lovely surprises that I found as a patient was that all of my physicians had a real bias toward there's always another room at the table. So if you've got another point of view, bring it in. And I was sheepish in the beginning because I thought, is it okay if I go see somebody else and get their take? And a friend of mine looked at me and said, this is not like buying a car. It's okay if you go to a different dealership. Others want good opinion. There's always more room for smart wisdom in this space. So I have a smart team. And even in that, I've learned I've had to advocate and bring on all kinds of what if questions and different scenarios to bear. And I'll just note also big picture, there's a real nuance here because I just want to observe that in the most optimal setting, I do think the more patients and physicians develop a true partnership and a true sense of engagement through this journey, the better the outcomes will be. But I want to just observe that can also be often quite intimidating for a lot of patients because we've been trained since we were little to sort of go to the doctor, get the diagnosis, get the prescription, and leave. We're typically not trained when we're 12 to start litigating whether or not you should take the antibiotic or not. I mean, so that's a real pivot from a disposition standpoint with how you engage with your physician in an exam room. And that can also be a little overwhelming because you think, well, wait a minute, if I don't ask all the questions, then maybe things will go left unsaid. And, I'm the only one in the room here who didn't go to medical school. Why is that on me? And so I would just encourage that there also be an abundance of humility to this and understand that patients are doing the very best they can with this new venture that they certainly didn't sign up for. And they're scrambling to try to stay up to speed. And now all of a sudden, they're part of essentially a team for the path forward. So appreciate that mentally, that can be quite a lot for a patient to carry. With respect to nutrition, a couple things I just want to say, and this might seem a little counter to prevailing wisdom. And so if that's the case, just say, well, look, she's one person, she's one patient, so you can set her aside. But for me, somebody who led a very healthy lifestyle, all of a sudden I have colon cancer, so I have cancer of my digestive system. Of course, in hour 3, your mind is just racing, thinking, what on earth did I eat? What on earth did I do over the course of my life that I shouldn't have done? You were frantic to try to figure out the why. The good news for me is I galloped past why pretty quickly and moved far more toward, what are we going to do? But I know a lot of people who can't get past chapter why, and that can become paralyzing. And one of the things that helped me quite a bit as I was trying to go back and figure out the nutritional backstory of what happened to me was when I met another stage 4 colon cancer patient, somebody even a little younger than I am, incredibly fit. This was like a long distance runner, and he's doing very well. And I asked him, I said, what do you think about, your diet? Like, what have you heard? What have they said? What do you think led to this? And he looked at me and he said, oh, I've been a vegan for 15 years. I mean, there's no way that I got this because it's something I hate. And I thought, you in that moment gave me permission to sort of exhale and to realize the great mystery of why this happened is one that is for the ages and that we need to spend a lot of time on. But it's really important that we give patients a little bit of permission here to exhale and to understand this is not a classic causal relationship of what you've done is now why you're here. And the main reason we're asking these questions is, of course, to ask, yeah, but what should I be doing now? And those are a better set of questions in my care team, which I think is pretty optimal. I'll tell you, I didn't get much. I got a binder that was sort of a brochure on good ways to eat, and it felt like things I got in the 4th grade. have a balanced diet, aim for lean meats and fish. Mediterranean diets tend to be better. I had one nurse whisper in my ear one night when I was recovering from surgery saying, you just, of all things, you have to avoid processed meat. And I said, okay. And then another person said, I don't really think that's a thing. I mean, like you end up in all of these different conversations, and what you're looking for are these lifelines. And I guess what I would just say is bring as much celebration and permission to understand that people around the world have such vastly different diets. There are good principles that we should hold, but there also should be an abundance of compassion as we all strive to be as healthy as we possibly can. I will just conclude by noting, of course, there are thousands upon thousands of different types of cancers who frankly do have very different nutritional frames that they need to work in. And that's a level of humility as well, because in my social world, as you can imagine, I got flooded with beautiful, well-intended advice from people who just had no idea what they were talking about with respect to my cancer. And how it feels as a patient is you leave that lunch with someone and you feel like they just gave me 5 new jobs, because now I have to go buy that cookbook and start cooking in a way I've never cooked before. And they're going to check up on me and try to figure out if I'm doing all of that. That can feel a little oppressive. And so I would just urge a level of sweetness for the patients to understand most of us are doing just the very best we can. But no, to Dr. Len's point, there might be a nutritionist in my oncology center. I've never met him or her, and maybe not. It's wild to me how it's not really top of mind. I could go looking for it. I haven't as much. Oh, one last thing on this though. The thing that I was most stunned about in terms of just broad, care for how I am as a person, I was stunned in the first 6 months of all of this. Not one person pulled me aside and said, let's talk about sleep. How are you sleeping?
Interesting.
And I'm a single parent and I'm pretty young. That in my mind should have been the biggest question of all, because can you imagine what goes through your mind as a single parent with this diagnosis? You're not sleeping, you're panicking. And if your body is not getting sleep after getting all of these really heavy treatments, that should be a major conversation. And I looked at my general practitioner, she's not a cancer person, and I asked her about it, and I said, I'm not sleeping. I don't know what to do. And she gave me a lovely prescription, very mild, for a sleep aid. And I looked at her, this was a great moment, and I said, I'm a little worried. What if I become a little dependent on that? And she smiled and looked at me and she said, what a great problem to have. If you get through all of this, and that's our challenge,
And that's our
we can
woe.
work on. That's a great challenge.
Yeah,
And
Adam, can I add on to some of the things that Amy has brought up, because they relate not only to nutrition but to overarching issues as well. Number one, let's talk about all the well-meaning people give you all the advice. I had a situation recently where somebody had a head and neck cancer. The surgery was going to be complicated, and they were told, somebody in the community said, well, you need to go on basically what used to be called the macrobiotic diet, and that will cure your cancer. And there were anecdotal reports of how the macrobiotic diet, and this person was almost ready to go to the diet. I don't say to people, oh, that's terrible. But when you have a cancer that has to be treated, I don't think that there's no real proof that the diet would work, and people have looked at those issues in the past. There dietary research. Let me come to something very specific that Amy said, because it has a very broad implication. There has been a substantial amount of research into diet and relationships to certain types of cancer. But there also is a lot of work, epidemiologic work, that looks at various things that cause certain cancers. Some we don't have any idea, others we have some for breast cancer. If you're obese when you're postmenopausal, you have a higher risk and so forth. And does losing weight, if you have postmenopausal breast cancer, help your survival, things like that. Certainly the red meat question is very high on the list. But you said something, Amy, that really struck, and that is, permission to forget about all of that, so to speak, and try to figure out that cause. There's a lot of shaming that goes on in the cancer to cancer patients and by communities when someone gets cancer, when they look at somebody and say, well, if you hadn't done this, or if you hadn't done that, or if you'd done more of this, or you'd done more of that, you wouldn't have gotten that cancer. The one that is most of concern is smoking and tobacco use. I think it's critically important that we let our patients know, as you said, the freedom to move on from all those questions, and that the blame game and the shame game stop, and we move forward with the opportunity to treat and help people back to what level of health they're going to achieve. And it's not just red meat in the diet, it's how much did you exercise? My golly, I go, Adam knows this, I go downstairs every day. I mean, I'm trying to put off that. There's a clock on the line that tells me when I should have expired. Literally, I wrote a blog about it yesterday, that I should have expired 2-3 years ago, believe it or not. I go down and work out every day, and I try to watch my diet, and yet I make, I do this and I do that, right? I've got, if I get a diagnosis of cancer, I've got to move on with my treatment and try not say, if I would have done this or would have done that, I would have been in a different place. So your comment is very important for everyone on this call and everyone who's not on this call to hear. We need to have patients under care without a sense of people blaming them for their cancer, shaming them for their cancer, but allowing them to deal with the disease and to move on to try to get back to the best state of health that they can. If I feel strongly about it, if I look like I'm intent about it, I'm intent, because it's a terrible issue, and it impairs people, particularly people with smoking related cancers. Mm-hmm. The first question everybody says, well, you smoked. Forget about it, folks. We need to get people into treatment, and we need to take care of people who are people with families and friends and children and parents. And that's what we need to focus on. And we need to get past this woulda, coulda, shoulda.
Yeah.
Completely agree. I will say the other thing Amy indicated, that obviously for those watching the video, my eyes lit up. I am incredibly passionate about sleep as it impacts health. And it's no secret, when I was at Fitbit, we launched a study around sleep and cancer, and we were part of so many studies around sleep and cancer simply because it was easy to track finally sleep stages through the night, and start really kind of thinking about sleep and its impact on medications, its impact on treatment, its impact on chemotherapy, its impact on quality of life. As a matter of fact, so much so that the first thing I did when I came to Jasper was I added Fitbit to Jasper so that patients could actually track their sleep. On average, a Jasper member sleeps about 6.2 hours a night. And they can look at that and look at their diet, look at their lifestyle elements as well. And I think it's so critical, but yet so missing from the broader equation. And one of the things, so first I wanted to say that, Amy, I'm glad you brought up sleep, because it's easy to go to some of the things that we do talk about a lot. It's one of those things that we don't talk about a lot, but we should be looking at. When we can quantify our sleep stages and start looking at, if we do this throughout the day, our sleep gets better, and it's quantified. Oftentimes we found at Fitbit that, you think you had a horrible night's sleep, but the data shows you actually had a good night's sleep. Or you think you had a good night's sleep, but the data shows you had a horrible night's sleep. We constantly, are being shocked by the quantification of things like sleep in a holistic care area. But I do want to move on to one area that I think.
So you won't let me say anything about sleep, huh?
Okay, go for it,
okay,
Dr. Len.
I
should have asked. I know you love the wearable approach as well. Go ahead.
Yeah, there you go. I always have to show my Fitbit. He knows it shows up in everything. and I do pay attention to my sleep, although I'm obviously at this juncture not a patient with cancer. But you're absolutely correct. And by the way, Huffington, Ariel, I'm blocking on first name. Huffington has been preaching this for a long time. And I'll tell you, I look at my sleep score every day, but let's talk about a larger question, which is also critically important. And Amy, you touched on a point without perhaps realizing what you're touching on. We don't do a good job of what are called patient-reported outcomes. We do not look at what's happening to our patients. I was on a call yesterday, and I think I can share, talking about getting feedback from patients about their sense of fatigue, their sense of emotional health, their sense of physical health, and trying to see how it changes over time and how we compare as a quality measure, compare practices. We are way behind. And yet, think about what you're just saying, what it would mean, and what Adam is just saying, the ability to take, in the case of sleep and Fitbit, is what I'm familiar with, taking a sleep score or doing analytics on sleep and understanding better what our patients are going through. A couple of years ago, I tried to tell people, to some researchers, that we needed to be measuring steps and activity and all the things that literally a Fitbit did. And I was told, just not accurate enough. And it was a case of the perfect and the good. We should have a much more robust and responsive system, hopefully one that doesn't require you to press buttons all day long, right? That works in the background seamlessly, gets information, and lets us better understand how our patients are doing. And I will just join in that sleep is an important part of that. Yeah. So thanks for bringing that up.
Yeah, no, and I'll just maybe add one more kind of broader context to this, because if there are other patients listening and you might resonate. We have all the data from our labs that we see and we learn how to read. And then we have these adjacent data that we have now through different technology and wearables that we have. And then there are questions that perhaps aren't asked that need to be asked, perhaps about, sleep and rest and candidly joy factors into this and other things. But what often happens for the patient is it tends to coalesce into a beautifully well-intended, but often crushing frame of a question, which is, okay, here you are, you're in a tough spot. Let's talk about the sort of path toward quality or quantity. And that's a really complicated space because nobody wants to hear or, you want to hear and. Let's go for quality and quantity. And now people come to that conversation at very different stages of their life. So somebody who's 84 and has prostate cancer is going to work with that question, I think, a little differently from someone like me. And I think there needs to be space for that. But what I have learned through the course of my care team, and I'm now about 3 years into this, and it was a revelatory moment that a beautiful, wonderful oncologist gave me, because I was really struggling at a juncture point. Should I do some more aggressive treatment or should I pause? And other patients out there will understand, candidly, the mental game there becomes harder than anything, because you think, how am I going to live in the next 90 days and not be doing anything about this? And he said, I recognize that if you pause, that will be intellectually a very hard burden for you to carry. And I said, yeah, I don't think I can carry it. I said, I would rather physically feel unwell, but know that I'm doing everything I can. And he looked at me very thoughtfully and he said, I want you to try to receive something here. In your time, what we're doing with you right now, we are looking for the longest game possible. And he said, your times when you are in quality mode, meaning you feel great. And I feel great right now. I haven't had chemo since September. I feel better than I have in 4 years. He said that quality leads to the quantity. It is an investment for what we're trying to do for the long haul. And you need to put your weight on that. You need to give yourself, again, permission then to say, I am now going to live as fully and as joyfully and as beautifully I can in this, not because I think this is my last window, but because this is actually making me healthier and I will be ready for the next chapter of what's to come. And that was a game changer for me. And so all of those factors about, how you're eating, how you're sleeping, how you are finding balance, and all of those things factor into quality. But what I didn't fully understand is that was actually a deposit toward this longer endeavor of quantity.
Absolutely. I do want to shift to something that Amy enlightened me many months or a couple months or a few months ago about, but it's how do we institutionalize, which may be a bad word or I don't know kind of word, but how do we actually harness the power of the shared stories and lessons learned of patients in actually structuring that co-architecting a care plan.
Yeah.
And Amy, I think I'm your biggest fan of your stories because I tell them so much, but it's so cool. Could you tell your story about the question you wish you would have known?
Yeah. Well, there's this tradition at the end of every appointment, most of us have probably heard, where it's almost time at the end when the physician will say, do you have any questions left for me? And you feel like, you're racing through your mind. If I have 5 more questions, then the appointment will go longer. But one of the things that I found through that is I, of course, found a lot of other patients, and you begin to compare stories, and you sort of wonder different treatment plans. A while back, I was at an interesting juncture point in the fall where I'd gone through a lot of chemo. I had a couple of persistent little mets in my lung that seemed to be resistant to the chemo. I had a consult with a surgeon. Unfortunately, one of the mets was quite deep. And he said, look, I'm not going to take out 25% of your lung for something the size of a raisin. Like, you're going to need that tissue later. So no. And I asked him, I said, well, what about SBRT radiation? I mean, could that be a path? And this was one of the top surgeons at UCSF. And he cared about me a lot. Like, I was getting everything excellent. And he looked at me and he said, that's interesting. Well, let's see if they'd be game for it. That's like not my gig, but I like it. Maybe try. Let's just see. And part of that, again, I'm going to just say that was an amazing moment where I realized, I am so co-architecting this plan. And then 5 minutes later, you're a teeny bit freaked out because you think, oh my gosh, what if I hadn't asked that question? Like, where would we be? So appreciate that comes with sort of a sense of euphoria and also a sense of, terror. At any rate, then I went to the radiation oncologist. She looked at my case. She said, oh, you're ideal. Like, this is great. I can't wait to get in there. Let's get these. And so I went through radiation. We worked through both of those mets. And everybody was like really thrilled with that. And you might look at that story and think, I can't believe they didn't bring it up. I can't believe they didn't advocate for it. And I'm not sure that that's a story that anybody did anything wrong. I think that's a story of physicians who listen well, a team that's ready to kind of move into their lane, a patient, frankly, who learned how to ask questions and knock on doors, a patient who got connected to others. And the last thing I just want to say in this, and this might be a little tricky for some, but I've really embraced it. What I have learned is whatever story I have to offer, and I'm hoping I've got years and years ahead of me. I may only have a few, I don't know. But whatever happens out of my case, I appreciate is going to then be kind of inserted into the greater canon of wisdom for so many hundreds of thousands of others. So I today am the beneficiary of someone perhaps 12 years ago who also asked a question about radiation and opened up kind of a field of the possible so that it became more routine in the conversations that I would be having on Jasper apps and others. And I do think patients need to revel in that we're doing something gorgeous, not just for ourselves and our families, but for someone we'll never meet 42 years from now. They are going to benefit from what we're about. And I wish that we had more language for that. I wish that physicians would embrace that and to say, you don't even get it, but you're doing something so important for the rest of us. And it's hard. It's a terrible thing. It's hard. I hate that you're having to do it, but you're doing it and you're doing it so well.
I've got to tell you, I wrote a blog on this topic about a month or so ago. And let me tell you the circumstance. I was on a webinar with another organization where I'm an advisor, talking about clinical trials. And the person who was with me on that particular call was had to be a young lady, a nurse from Toronto, Canada. It's public information. And she went through what happened, her journey, and she told it very, very well. And it struck me in that moment, all the decisions and all the things that happened in her care were the summation of all the things we had done, not that I had done, but that we as a profession and patients together had done, literally over a 50-year period of time. I remember when breast cancer, when mammography started and came into clinical practice. I remember running clinical trials out of my private oncology office, along with other, I was part of a much larger group, looking at adjuvant therapy for breast cancer. I remember when the surgery for breast cancer changed. I remember when we went through all the things about adjuvant therapy, what was the right duration and everything else. I remember when clinical trials showed that Herceptin made a huge difference, and particularly for young women with aggressive breast cancer. And so here we are after 50 years having a conversation, and the decisions are book, right? Maybe there's some choices along the way, and realized that that treatment for that person at that moment, at that time, was, and I get maybe a little emotional, was the culmination of a huge number of people, patients, families, clinicians, researchers, government, foundations, companies had put all of that effort together to get to the point where that person, that woman on that webinar at that moment was able to make choices about her care and where the options were. You are absolutely correct. And I wrote in the blog, and you said it, the exact same thing. You will never know those who made the sacrifices and the commitments of their lives in a terrible situation that made your life so much better. You'll never know. You'll never meet them. You'll never know about them. And yet, just what you said, Amy, they make a difference. We all make a difference by contributing our knowledge, our situation, our willingness to help others, and people will never know in turn. It's what you said is very real, very important, and makes a difference every day. And those folks who made those contributions are angels.
Yeah.
They're angels.
Well, ultimately, we all will be, wherever all of us are going to get diagnosed with something. I'm certain of that. All of us will be. But in this particular community, again, I just think there's a chance here to bring much more kind of gentle, purposeful language to this that also empowers a patient to understand, okay, now I'm part of a grander story. And that also, I think, can help equip you to push out and to say, so what do we want to create here? And I mentioned yesterday to Adam, one of the things that I really loathe in the discourse of cancer is just this notion of she lost her battle with cancer. And I think most patients would agree we all hate it, but we don't know how to talk about why we hate it. Because, well, first of all, nobody wants to be a loser. I mean, when you die, nobody wants to choose a loser. But what this really is for me, for at least the metaphor that makes much more sense, is this is much more of a dance. You were moving through a constant place of experimenting, of sometimes joy, sometimes exhaustion, and you're pivoting as the circumstances require. And I think we all can learn how to dance far, far better. And it shifts, I think, that sense of hierarchy as well in the physician room, because then you can begin to explore all kinds of possibilities. I mean, for me, I'm in a fascinating juncture point because I'm not actually sick right now. I feel great. I feel better than I have in years, but I'm really not well because I still have little persistent mets in my lung, and we have to pay attention to that. And I'll probably have more chemo this summer to get after it. So I live in the great in between. But if you step back, you realize actually, it turns out most of us probably live in some measure of an in between. Mine's no longer abstract, it's quite real. But that's where finding the path and co-architecting and all of these other value-based principles that we've been talking about come into the most kind of animated way, because you're full of subjective what if conversations that I think can benefit yourself, but also hopefully thousands more to come.
Totally
I
agree.
want to, can I comment briefly on the battle metaphor? Because once again, you've touched on something that has been top of mind for some of us for a long time. And particularly, it sort of rose to a level when John McCain became ill and everybody's talking about his final battle, right? I think we have to be very careful about battle metaphors. Maybe a personal opinion, maybe not everyone shares that. But as you mentioned, does that mean the person who passes on didn't fight hard enough, didn't do enough, didn't care enough, whatever the enough may be? We have to be very careful about that. And I appreciate the fact that you mentioned that, because a lot of people use it, and it can be, frankly, for some patients, it can be problematic. Let's put it that way, and for some clinicians as well.
Completely agree. You know, as we close out this dialogue, first of all, I do want to say thank you to both of you. You know, it's so often we get on webinars and we have dialogue, we have slides presented, frankly, on solutions. And we have far less dialogue about how do we actually bring folks together. How do we also look at things and then bring it back into how do we start making things very tangible and real leaving the webinar? I don't believe in webinars are we have tons of time, so why not just join one and just listen? I think they should be actionable in nature. We heard today about that holistic care, the psychosocial elements of care, the idea that there should be a team-based approach. We all believe it. I don't think there's anyone that would debate it. You know, we heard also shared knowledge and peer knowledge sharing in a very thoughtful way. And the power of so many experiences throughout the decades, culminating into where we're at today, that would actually allow us to provide tools and resources and education for patients to be more empowered, to make choices that frankly, they may not even have ever known that they could have ever made. I'd like to get just some final thoughts as we close out on, you know, how you see the tangible next sort of, say, 12 months in this area of adding value, not necessarily to value-based care, but to oncology from a provider and a patient advocate perspective. Start with you, Dr. Len, and maybe we close out with Amy.
I'd rather hear from Amy first, but I'll go ahead if you want.
We have to, I'm sorry, but yeah, that's how it goes, my friend.
Okay, well, Amy's going to be the closer. I know she'll do fine, so not a problem. I'll tell you what I think about these days. I think about how we get care to people effectively and meaningfully. We went through a pandemic, went through a period of time when went through a lot of revolution and evolution in care delivery. It's pretty clear we need a new model. We cannot continue the way we're doing it. The silos, the balkanization. You talked about going to see the doctor. I'm familiar with a major medical center near where I live, where the patients show up late to the office because they can't get a parking space. Or how do we get chemotherapy in a different way? How do we connect in a different way? But looming over all of this is how do we at least start using the tools that we have in every other industry and part of our lives to get care and help to people where they are. I'm not going to say that every visit has to be virtual. Maybe not. There's, you know, some people want more touch than others, but you don't have to have somebody travel 2.5 hours to come in to hear a 5-minute conversation. How do we get navigation that really is meaningful navigation? How do we get mental health care? How do we get financial care? How do we get dietetic care? How do we get somebody to listen when you just want to be able to talk? And I would hope over the next 12 months, and yeah, maybe this has a lot of Jasper tone to it, but that's why I'm here. And I'm here because I do believe that we can harness the tools in such a much better way. Patient-reported outcomes, analytics, being proactive, creating connectivity. Maybe it's not as personal as everybody would like, but I can't have a financial counselor in everybody's office. I can't have a nutritionist in everybody's office. I could, you know, all these things, and build out a system where people come first, their needs come first. I'm sure Amy has a much better way of articulating from the patient perspective, but from a structural perspective, we need a really very thorough reevaluation of what is value, who defines value, how do patients perceive value, and how can we create value so we get back to a place where clinicians, nurses, doctors, PAs, dietitians, social, where they're part of a team and people can connect and feel they're part of something greater. Because when somebody says, and Amy, you alluded to this, when someone says you have cancer, the world goes away. You're in a much different place and you need all the help and all the support. And you need to be able to go somewhere to be able to find that without having what I hear about goes on so much. We have no idea where to turn. You need somebody to help you through that journey. So yeah, I would hope the next 12 months, that's where we move forward.
Amy?
Hi. Well, I'll conclude by saying a couple of things. One is cancer is such a hassle. I mean, it's awful. Life, there's before and after, and life before was so much better. So much better. But here we are. And I will just say that I'm going to say just kind of three things to close this out. One is for patients or those who know patients or love patients or work with patients, give us a lot of space to understand that whether you're on day one of a diagnosis or day 1,000, you know, we're doing our very, very best. We're often really confused. We're not terribly coherent, and we're navigating just an infinitely complicated new planet that nobody signed us. We didn't sign up for, and I think most bring all of that compassion, but it sometimes it's okay to remind folks, understand just how bananas that is. The second thing is for me, and what's really been helpful, at least for my own mindset, I have absolutely fallen in love with science and the medical community. I never paid attention before like I should have, but I'm captivated by the rigor, the commitment, the beauty, the magic, and just the tenacious commitment that practitioners have been at for hundreds of years now, and certainly more so than ever right now. And so there's a depth of gratitude now that I find just awe-inspiring, and that really does help me in my most complicated and tender moments when I have a hard scan. That space of awe is an important one. And then the last thing I just put in the chat, I learned the most, candidly, from what I call the soft conversations that happen after an appointment, sometimes with a nurse, sometimes with another patient, sometimes in a waiting room. I learned the most about, you know, everything from, oh, have you tried those little gloves? They help so much with neuropathy. And when you lose things on your hands, like, no one ever told me that. Listen, ask as many questions as you can. Give yourself permission to not necessarily take on somebody's new jobs, but bring a true sense of curiosity and wonder to all of it. And you may be able to pass that along to others. I write about my own trek on the blog I just put in. There's a lot of cancer, there's a lot of other things. But I'll just conclude by saying I'm also just deeply mindful of the fact that I know my own case someday will have deep benefit for those who will come after me. And that doesn't mean that makes it okay by any stretch. This is a lousy hand I got dealt, but it does give it some purpose. And I think that's an important North Star as I continue to have at it with this dance. So thanks. This was a good conversation. I'm glad we had it. And yeah, invite me back sometime. I'd love to keep at it.
Thank you so much, both of you. Amazing dialogue. I'm glad it was a dialogue and not just PowerPoint slides and talking points. Thank you again. And thanks all those who attended the webinar. Email me if you have any questions. I'm sorry we didn't open up Q&A, but I thought dialogue was far more important. than technology on this. So thank you, Ehi. Thank you, Amy. Thank you, Dr. Len. And until next time, we'll see you online. Take care.
Great.
Bye.
Thank you, everybody.
Bye, everybody.